So the goal of today's presentation is to provide you with information on the latest advances in digestive system research and how the next round of redevelopment at our hospitals will benefit patients who have this kind of clinical care need. I'm going to introduce Drs. Banner and Fleming and Petroff, and I'll start off by letting you know a little bit about Dr. Banner. So Dr. Stephen Banner received an undergraduate degree in life sciences and a concurrent MD and MSc degree from Queen's University. After completing his internal medicine and gastroenterology training at Queen's, he carried out postdoctoral research in enteric neurophysiology at the Bollum Institute in Portland, Oregon. Since returning to Queen's University in 1991, he's been an attending staff and gastroenterology at the Kingston General and Hotel View Hospitals, now Kingston Health Sciences Center. And he cares for patients with gastrointestinal disorders in both the inpatient and outpatient departments. He performs a full range of endoscopic procedures. He has subspecialty expertise in gastrointestinal motility disorders involving the lower GI tract, and he is director of the Anorectal Motility Laboratory. He has an established translational research program that examines mechanisms underlying heme signaling and motility in the gastrointestinal tract. He's published extensively with more than 6,000 research citations. My goodness, I don't know how you have to get up in the morning. Please join me in welcoming Dr. Stephen.
Well, good morning, everyone, and thank you very much for this invitation to come and speak to you. It's not very often that I get to come and speak to such an enthusiastic and vibrant group, and particularly one that has my mother in the audience. So I'd like to tell you two short stories this morning. The first one is about the Gastrointestinal Diseases Research Unit and what it takes to create a world-class research organization. And the second is a short story about my own personal research and really to tell you a little bit about that, but also emphasize to you some of the changes that are happening and the complexities that are involved to carry out research today. So first, the first story is a little bit about the GI research, and that's the beautiful building that we have that's attached to the Kingston General Hospital. And this is where it all began. So this is a picture of taken, I think, in the late 70s. And some of you will probably recognize some of the people in this picture. But this is Ivan Beck, who came to Queen's in 1961 from McGill, and he was one of the fathers of starting the GI research unit. I mention this because that's 1961 and we're in 2017. It takes a long time and a lot of effort and a lot of people to create a research facility like this. Some of you will remember Larry DaCosta. This is Dale Mercer, who just retired. And Jerry Simon, Jerry Morris, who's head of biology. Bill DePue just retired. My colleague Bill Patterson, who's been head of the division for many years. So these people played a pivotal role in getting the GI research unit started. Over the years, we've been very fortunate to recruit people from around the world, and this map shows you, here we are on the red dot, and people have gone away and trained around the world, and we've been very fortunate to get them to come back and join us in Kingston. And our group is very multidisciplinary, so we have members of the group from a whole host of different departments, all contributing to GI research. This is a recent picture. Whoops. So this is a recent picture of the group taken at Summer Hill at Queen's, and you can see we have many students and faculty all working hard in this common cause. We've been very fortunate on the hard work of many individuals to have a number of successes, and I'll just mention a few of these. We were the first training program in Canada for GI motility disorders, and we went across the country educating other physicians about these common disorders. Bill Patterson led a large multi-million-dollar grant that led to the building of that beautiful facility that we have now attached to KGH. He also spearheaded a training program grant, so we had the first training grant for students in digestive sciences in Canada. Had that program for almost 14 years before they phased it out. More recently, we've been successful in getting another Canadian Foundation Innovation Grant for almost $3 million, and we've expanded our research program, not just at the cellular level and at animal translational models, but now into human applications as well. And some of you may have seen in the newspaper that we joined as co-applicants a national study, $25 million study across Canada to enroll 8,000 patients with inflammatory bowel disease and irritable bowel syndrome into this large cohort of patients to try and understand how diet and the microbiome can influence disease. We've been fortunate to have a number of what we feel are very important discoveries. I'm sorry I've got my back to a few people, and this is just a few of them, and I'm going to hear more about these today. So microbiome therapies is a very exciting and important area in GI research. I'm sure you've read about that, and Dr. Petrov is going to tell us about this exciting area. We've had important discoveries and new targets to treat Crohn's strictures, which is inflammation and narrowing of the bowel. Many of you in this room, I suspect, will have had a colonoscopy. I certainly have, and you know that taking bowel prep is one of the more exciting parts of it. And probably the regimen that you took, we had something to do with it, because we've done a lot of research in this area. I've got colleagues working on satiety signaling and how increasing weight can affect hunger signals in our body. We're understanding how liver disease is impacting on us and what some of the factors are that are driving that. And Dan Fleming's going to tell you more about this very important area. And my own work, most recently, has been looking at diets and how they might influence irritable bowel syndrome. So that's a little snapshot of the GI research group, some of the areas that we're working in. I'm going to just spend a few minutes telling you a little bit about one of my areas of interest in research, and then I'll pass things on to my colleagues. So, irritable bowel syndrome. Imagine a condition that affects 15% of the Canadian adult population. That's a lot of people. Next to the common cold, it's the second commonest reason why we're either absent from the workplace or from school. So it has a huge impact on us. It's a condition that's characterized by abdominal pain and altered bowel pattern. And I think the frustrating thing both for patients and for physicians is when we look inside the bowel, such as this picture through a colonoscope, the lining of the bowel looks completely normal. So we really haven't understood this condition despite how common and the impact that it has. And because of that, we don't have particularly effective therapies. Fortunately, we're starting to make some inroads here. And so one of the things that we've been doing is through this colonoscope, we can actually take a little biopsy. And we can pinch off a little piece of tissue. And we can study some of the signaling mediators that are in that tissue, even though the lining looks normal. And the way we do that is we actually use mice, and we take the nerves out of the mice that innervate the colon, same as in a human. But we take them out of the mouse, and then what we do is we take those neurons and we take what we call a supernatant from that biopsy I just showed you. So we incubate that biopsy and we cut the fluid off it, that's the medium, put it on the nerves, and we see how it changes the signaling of those nerves. And we do that through a fancy recording technique. And what we record are what are called action potentials. And these are electrical signals. And that's how nerves talk to each other and eventually talk to our brain. And the more of these signals they send, the more information your brain's getting if something hurts in your gut. And what we found is, even though that lining looks normal, those biopsies are making those nerves hyperexcitable and sending too many signals to the brain and making us feel so we wanted to know what is causing this, what we call immune activation. Why are there mediators in our gut that are signaling to the brain and giving us pain? Well, one of the things we've known for a long time about irritable bowel syndrome is that food can trigger symptoms. And so, most recently, it's been discovered that even healthy foods have sugars in them that we don't digest very well. And this is a fancy name for them called FODMAPs, which is an acronym. But basically, these are fermentable sugars in healthy foods. These are foods that are high in FODMAPs, and these are foods that are low. And you can see they're all healthy foods, but they can cause symptoms. So we did a clinical study in patients who had irritable bowel syndrome, and some of them we put on a low FODMAP diet, we cut down the sugars, and we followed their symptoms, and you can see that just about everybody got an improvement. We put some on a high FODMAP diet, and they either didn't get any better or their symptoms actually got worse. So the question is, what are these sugars doing that are giving us symptoms? So here are the sugars. We digest them, and they get down into our microbiome. These are the bacteria that are in our gut, and the bacteria ferment them or break them down, and they cause these active metabolites. So we are interested to know what these were. And you remember, if I take you back to these biopsies, that there's something triggering immune activation in these biopsies. And so what we came up with was we saved all the stool from the patients that had gone on these low and high FODMAP diets. And some of them had high immune activation and some of them had low. So we thought, well, let's see if the microbiome could be important in driving these symptoms. So we went back to our mouse model, and we collaborated with our colleagues at McMaster University in Hamilton because they have a germ-free facility. So these mice have no bacteria in them. The bacteria from our patients, we put them into the mouse. So we humanized the mice. And then we put them on the diet. And now, because we're looking at a mouse model, we can study them in more detail. And so when we take the colons in these mice and we distend them with a balloon, we can look at the nerve activity. And so when we took the bacteria from a patient who had high levels of immune activation and we put that in the mice, we found lots of neural activity signaling gut pain. But when we took another patient that didn't have a lot of immune activation and we put their microbiome into the mice, we saw a lot less. So it told us two things. One is that diet can trigger symptoms, and two, that our microbiome, depending, and each of us has a different microbiome, could be playing a role in it. So there is, we think, light at the end of the tunnel. We think that diet could be important. We found new drug targets, and we think that microbiome therapy potentially could be important for some of these patients. So I'll just conclude there and just end by bringing you back to the GI Research Unit and telling you that our biggest challenge today, many of you know that funding is extremely difficult to get. The funding rate at CIHR now is 15%. So every 100 doctors that write a grant, 85 of them don't get their grant success. So it's very, very challenging. And obviously, in order to carry out the work that we're doing, we need funding for the experiments to support our students and our research staff. And many people in this room have supported us, and I just want you to know that we're extremely grateful. So thank you for your time.
So what does our liver do? Well, our liver is a very complex organ. It's located right up on the right side of the abdomen and has over 500 different functions. I like to think of it as kind of the filtering organ of your body. It processes all foods and toxins that you ingest. It metabolizes all the medications that people take. It also stores energy after we've eaten. It stores energy there that we can use later when we're in a fasting state. It is responsible for your cholesterol regulation. It's involved in blood clotting. It has a very important immune function in your body. And it also produces your sex hormones and thyroid hormones. And these are just a few of the functions that your liver does. What most of my research looks at is the condition called liver cirrhosis. So I'm sure that most of you have heard of this condition. And what cirrhosis is it's the end stage of any sort of chronic liver disease that can result in injury and damage to the liver over time. And most causes of liver disease are actually related to our environment. As I said, it is the filtering organ for all the toxins that we ingest. So most of the time, things that injure the liver are things that we get exposed to in our environment. And I think what I see when most of the patients I see think that liver disease is only related to alcohol use, and I would have to say that's probably the third most common reason, but it's definitely not the most common reason that I actually see patients in clinic. So I like to try and get that out to the audience because I think there's a big stigma associated with liver disease and cirrhosis, and I think that that will need to change into the future, as you'll see with some of the research that I've been working on. So this here is a normal looking liver. It's nice and smooth. And what happens when you have a chronic liver disease, whether it's related to alcohol, hepatitis C, fatty liver disease, what happens over time is your liver gets injured and damaged. And what happens is your liver continues to try and repair itself over time. And over 10 to 20 years of exposure to whatever injury is causing the liver disease, a certain amount of people will develop liver cirrhosis. Once you develop cirrhosis, there are many things that you're then at risk for. It increases your risk of liver cancer. It increases your risk of liver failure and needing a liver transplant. So as mentioned, alcohol is actually not the most common cause of cirrhosis in this day and age. Actually, the most common cause is probably now non-alcoholic fatty liver disease. I'm sure most of you may have heard of fatty liver. Maybe your doctors have even told you that you have a fatty liver, and I wouldn't be surprised because 1/3 of the population in general is thought to have fatty liver disease. And this is a condition that has only been recognized in the past 20 to 30 years. It was never described in the literature before 1980. But like I said, it is now affecting 1 out of every 3 individuals in Canada and the United States. It's also the most common chronic liver condition in children. Up to 10% of children now have fatty liver disease, and of obese children, up to 80% of them have found to have fatty liver disease. And this can lead to cirrhosis. The next most common thing I see is hepatitis C. Hepatitis C is a virus that can lead to liver damage over time. It's most common, 70% of infections of hepatitis C are actually in the baby boomer population. So the average person I see with hepatitis C is usually in their mid-50s and 60s. And again, this can lead to cirrhosis over time. And then the third would be alcohol. And alcohol-related liver disease is not only confined to people who we would classify as quote-unquote alcoholics. I see people with alcohol-related liver disease who consume minimal amounts of alcohol over time, but in certain people that can lead to long-term liver damage. So like I said, most of chronic liver disease is related to environmental exposures that we have. So knowing now that fatty liver disease is affecting 1/3 of our population and it can lead to cirrhosis, everyone in the liver community has assumed that cirrhosis is going to be becoming more common as time goes on. But no one's ever been really able to describe the exact burden of cirrhosis in our population since fatty liver disease was described. So that leads me into my health services research program. So what is health services research? So it's a bit of a different type of research program as compared to Drs. Banner and Petroff, who work in the lab. They use animal models, they can use patients. Most of my research I can do sitting down in front of a computer. So what health services research does is it focuses on the delivery and access to medical care, in contrast to other more traditional programs which focus on therapeutics and experimentation on individual patients. So the goals of health services research are really to describe the burden of diseases in populations, to determine whether medical interventions result in the anticipated outcome. So once there's a clinical trial that suggests benefits, so for example, for Dr. Banner, if he prescribes FODMAP diets and that improves symptoms in a clinical trial, does that actually translate to benefit once you spread this intervention to the general population? We also try to identify the most effective ways to organize, manage, and finance and deliver high-quality health care. And it also provides us with the ability to study very rare diseases. So you can imagine if you just took everyone who came to Kingston Cell Sciences Center with a very rare disease, you would only be able to study 1 or 2 people. However, if you use large databases of people, you can gather information and get a more clear picture on what's happening with those sorts of conditions. So how do I do this research? So we use very large-scale population data on patient characteristics and their healthcare utilization in order to look for associations and generate research ideas or discover information that can influence healthcare policy. So I am a member of the Institute for Clinical Evaluative Sciences, as we short-term it ISIS, not to be confused with the other ISIS member of that. But it's an independent nonprofit organization in Ontario that has been assembled with its main headquarters at the Sunnybrook Hospital in Toronto and has satellite centers in most academic centers, including one here at Queen's. And what ISIS does is it collects all the data from all the healthcare utilization of all individuals within Ontario. So using your OHIP number, which identifies a unique individual, you can follow different access to healthcare. So how often do you go to the emergency room? How often are you admitted to hospital? Who are you seeing? What sort of medications are you on? Etc. So the way I like it to describe it is you can imagine that there's over 13 million people in Ontario, many of whom are all accessing the healthcare system at different points in time over long periods of time. So if you looked at this data, and I'm using these bottle caps as an example, it looks just like a jumbled mess. There's all sorts of things, there's no pattern, there's nothing that you can actually take home from this. However, when we use our statistical health research techniques, what we try and do is take this jumbled up mess and turn it into patterns so that we can tell stories and look for different associations. So ISIS has been very successful in producing high quality health services research. These are just a couple of major publications that have influenced health policy that have come from this type of research. So this one here, for instance, was actually determining the association between cell phone use and car accidents. Again, by using these large databases and trying to look at patterns. So what my group did is we wanted to look at all the people in Ontario who were diagnosed with cirrhosis, and we wanted to look and see how that pattern was changing over time, because we knew that the influx of fatty liver disease was high over the past 20 years, and we wanted to see how that impacted what was going on with patients with cirrhosis. So the way we tried to tease that out is we divided people based on when they were born. So if you were born before 1945, the most common reason for cirrhosis would have been alcohol, because hepatitis C wasn't around, neither was fatty liver disease. If you were a baby boomer, then hepatitis C came along, so that would also increase your risk of liver disease. And people born after 1965, that's when fatty liver disease would have started to come into the population. We wanted to see how this differed in men versus women. So using these large databases and trying to sort out these patterns, we were able to show that the number of people in Ontario with cirrhosis has increased by 148% over the past 20 years. So in 1997, 0.37% of the population had cirrhosis, and last year it was 0.92. So almost 1 out of every 100 people in Ontario now has liver cirrhosis. The interesting thing that we were able to show is that it actually wasn't older people who were contributing most to the disease. It was actually young people. And as traditionally thought that cirrhosis is a disease of men, the rate was going up highest in women. So this is just a little graph to try and depict that point. So here we have the number of people with cirrhosis and at what age they were diagnosed. So these are only people under the age of 40. So we're looking at young people who were diagnosed with cirrhosis. Then we look to see which year they were born. So the green are the baby boomers. The red are the Gen Xers, we call them. And then the blues are the millennials. And what this red line shows is looking at the number of people with cirrhosis at the age of 32. And what we showed was that at the age of 32, you were 56% more likely to have cirrhosis than if you were born in the baby boomer era. We also then looked at what these trends look like in men versus women. And you can see that for both men and women, once this 1980, again, that's when fatty liver disease was described, this graph sharply goes up. But the increase is more dramatic in women than it is in men. So that was somewhat of an unexpected finding. So what do we want to do with these findings? Well, number one is the burden of disease is increasing at a rapid rate. And what effect is that going to have on our healthcare system? Because we know already individuals with cirrhosis place a huge burden on our healthcare system. The second thing is what sort of public health interventions can we translate into the Ontario population to prevent this from happening? Because as I said, most causes of liver disease are due to environmental exposure factors. And what do we need to do? Do we need to do dietary interventions for fatty liver disease, decrease the rate of transmission of hepatitis C, and discuss alcohol use, especially in younger generations? And what I'm actually very interested in is what's happening to these young women. So as I mentioned, cirrhosis is thought to be a disease of older men, and now we're seeing that the trends are going up more so in young people as well as women. So these are my children, your grandchildren, and how are we going to try and prevent this from affecting future generations? So with that, I'd like to thank you for your attention.